Good evening and welcome to the Florida Society of Interventional Pain Physicians webinar. Thank you so much for joining us this evening. This webinar will begin promptly in 2 minutes. Thank you for joining us, and we will be with you shortly. Good evening and welcome to the Florida Society of Interventional Pain Physicians webinar. Thank you so much for joining us. The webinar will begin promptly in 1 minute to give everyone ample time to log on. Thank you for joining us. We will begin in 1 minute. Good evening and welcome to the Florida Society of Interventional Pain Physicians webinar. We are so glad you've joined us this evening. I would like to introduce our moderator this evening, Dr. Jesse Lipnick. Jesse, take it away.
Thank you, Michelle. Hello, everybody. I am Jesse Lipnick. I'm the president of the Florida Society of Interventional Pain Physicians. For anybody who doesn't know me, I'm still at my first job out of school with SciMed Health in Gainesville. I'm a private practitioner. My training is in PM&R. I carry certifications also in electrodiagnostic medicine and also in pain management. I'd like to start by thanking everyone who has put this webinar together. First of all, for the teaching and sharing that you're about to hear, thank you to Michelle Byers-Robson of Mantra Meetings for putting all this together. Michelle does a marvelous job for us and she makes all this possible. I'd also like to thank the Florida Society of Interventional Pain Physicians Board of Directors. These people are the most talented and dedicated group of physicians in the nation. I will be introducing each one of them to you as he or she comes on for the presentation. You have the slides in front of you for each speaker. I will introduce all of the speakers to you, and I will be brief. Believe me, everybody provided me with pages and pages of accolades, training, and wonderful accomplishments, but I'm going to sum it up in about 2 sentences. We are going to start with Dr. Gautam Kalyatanda. So, Gautam is a clinical assistant professor at the University of Florida, Division of Infectious Disease and Global Medicine. His specialty before COVID-19 was treating tuberculosis patients with the Florida Department of Health. He focuses on delivering primary care to underserved in rural India. He's part of a number of global health organizations, including Karuna Trust, Vivekananda, and he now serves on the COVID-19 service at UF and the CDC. He will cover epidemiology, pathophysiology, and treatment. With that, I give you Dr. Kalyatanda. Thank you.
Thank you so much, Dr. Lipnick. It's indeed an honor and a pleasure to be presenting at this webinar today. Let me start off. Coronaviruses are a large group of viruses infecting mammals and birds. It was first isolated in 1965 by Terrell and Benoit. It was cultured from the respiratory tract of a boy with a common cold. In 1968, it was given the name coronavirus because it looked like a crown, mostly because of the S proteins or the spikes that you see over the virus. Now, just going to the virus itself, it's an enveloped virus, 60 to 140 nanometers in diameter. It's a positive single-strand RNA with a genome of a 30 kb weight. It has the N protein. It also has about 3 surface proteins, the most important being the spike, which forms knobs and is associated with viral entry, tropism, pathogenicity. It also has the other 2 membrane proteins, M and E. Next slide, please. So that's again a small figure there with, if we can go back to the earlier slide. Yeah, so the most important thing is the spike proteins S1 and S2, which attaches to the ACE2 inhibitors in the lung. Now, the S2 is an extremely conserved region between different species amongst the coronaviruses, and so that might be a potential therapeutic target. So again, you have the nucleocapsid membrane and the envelopes proteins there. So next slide, please. So the subfamily orthocoronavirinae has 4 genera: the alpha coronaviruses, the beta coronaviruses, the gamma and delta coronaviruses. So the alpha and beta are usually seen in bats and rodents, and the gamma and delta are seen in avian species. Now, amongst this, you will see 2 alpha viruses, HCoV229E and the HCoV NL63. You'll also see 2 of these in white, HCoV OC43, which is a beta coronavirus, and the HCoV HQ1, which is a beta coronavirus as well. So these 4 form kind of they are the causes of most of our common colds, and don't really cause any major infections except in elderly populations. Now, the other 3 beta viruses, the SARS-CoV, which was associated with the outbreak in 2003, the MERS, which is the Middle Eastern Respiratory Syndrome in 2013, and more recently the SARS-CoV-2, which from the outbreak in China in 2019, that are associated with more severe infections, acute respiratory distress syndromes, and increased mortality. Next slide, please. Yeah. So the transmission. So the initial cases, when they were reported in December, were thought to be, or at least linked to the exposure at the seafood wholesale wet market in Wuhan. So there was a lot of animal, it was thought that there was animal to human transmission, and this goes back to the previous studies with the coronaviruses, the SARS, where the palm civet and the raccoon dog were associated as intermediate hosts. We still don't know what the intermediate host in this case is. Since then, I think it was the 3rd week of January or late January that the WHO then came out and released a statement saying that there was human-to-human transmission. Now, one of the questions is, what percentage of this population will transmit the disease before symptoms? And again, there is the data kind of goes all over. It depends where you get it from. It's very infrequent, so we don't know the exact rates as yet. So in terms of transmission, there's both droplet and aerosol transmission. Next slide, please. So there has been no direct research-based evidence about how it's transmitted. We know that there is aerosolization, especially in aerosolizing generating procedures like intubation, etc. And there is also droplets. Droplets seems to be the main driver of these infections. But the problem is the guidance from most organizations have been inconsistent and sometimes conflicting. So it's been extremely difficult for both the general public and the healthcare professionals to kind of decide on what mode and then take protections based on that. Next slide, please. So going to the pathogenesis, there's 3 surface proteins, S, M, and E. So most important is the spike protein, as we described earlier. Now, from MERS and SARS, the previous infections, we know that it binds to the human ACE2 inhibitors. Now, the MERS infects the DPP4, so there's a change in receptors there. But it affects these cells. There's replication in these cells. There's progression to alveoli. There's fluid leakage, and then there's respiratory failure. Might be a little more complicated than this, at least with the SARS-CoV-2, primarily because we're seeing a lot of cases with microthrombi, and that might have some association with these clinical features. Now, again, this is a figure quickly, but you can see the spike protein, which attaches to the ACE2 inhibitors. There is translation of viral polyproteins 1A, 1AB coming down. You have the replication transcription complex, and then forms subgenomic particles and the genome, and there's exocytosis causing reinfection amongst these cells. Again, basic pathophysiology, we know there is increased neutrophils and there's lymphopenia. So how does this happen? We know that the CD4, CD8 T cells are reduced. There's increased TH17 in CD4 cells. The CD8 T cells, a high concentration, high concentration of cytotoxic granules in them. Next slide, please. And this might be through the TH17 pathway causing the cytokine storm from the CD8 T cells as well, that causes a lot of the pathology that we see in COVID-19. Next slide, please. Okay, so this is a simple figure here. Now, just kind of give you a brief outlook. It affects the alveolar type 2 cells because that's where the ACE2 inhibitors are, and it kind of inhibits the interferon 1 pathway. So when it inhibits the interferon 1 pathway, which is needed to control virus replication, you have the TH1, TH17, which possibly causes increased macrophages, neutrophils, which cause a lot of the ARDS features that we see in some of these conditions. Now, again, this all goes back to the SARS. We don't have actual data about what's causing or what's driving these things in the COVID-19 infection. Next slide, please. So what about the rates of infection? So about 3 million cases worldwide with about 210,000 odd deaths. There's close to about 1 million cases, or we did pass that 1 million case mark today, with about 55,000 deaths. Again, just a comparison with the flu in the US. So it does have an increased case fatality rate, but again, that depends on the denominator, and we don't know what the denominator is. Next slide, please. So what are the clinical features? So again, the median incubation period is about 4 to 5 days, and 98% of patients will have symptoms within about 12 days. This again goes back to some studies from China. What are the symptoms? You have fever, cough, sore throat, malaise, myalgias. You have some gastrointestinal symptoms like anorexia, nausea, and diarrhea, anosmia, ageusia, and there's shortness of breath. But from most studies in the US, about 85% have cough, 85% also have fever and chills, and about 27% have GI symptoms. So going to the treatment part of this, and this is where it gets complicated, there's really no proven therapy. And if you go back to the IDSA guidelines from the 14th of this month and a modification on the 17th, so what they basically say is all therapy is based in the context of a clinical trial. So let's go to the first one, which has got a lot of press as such: hydroxychloroquine, chloroquine, or hydroxychloroquine with azithromycin. Now, a lot of us used this earlier on, but there are lots of studies that are coming out that are saying that one study, about 10% of patients had QTC prolongations, which is a problem with both azithromycin and hydroxychloroquine. So we've got to be really careful with elderly patients. Can cause hypoglycemia as well. So are we using it? Yes, but is there any data? Probably not. Small studies, there was all of this started with a small study in France, which looked at about 20 patients. The methodology is questionable, and there was no control group. So at this time, yes, if it's moderate, we would use these drugs. Again, bearing in mind, looking at the QTC prolongation side effects profiles would depend on how we would treat them. Next slide, please. So the IDSA also recommends a combination of lopinavir, ritonavir, which is Kaletra, in the context of a clinical trial. But there have been some studies which have come which showed absolutely no benefit, so we don't use it, at least at the University of Florida anymore. Again, amongst patients who've been admitted to the hospital with COVID-19 pneumonia, there is no role for corticosteroids. So going back, there were some studies from the MERS epidemic and the SARS initially, which said use of corticosteroids prolongs viral shedding in some of these patients. So we don't use it routinely. Next slide, please. So when would we use corticosteroids? Possibly in patients with ARDS, and that's what we are doing. If they're in shock, respiratory shock, or septic shock, we would use corticosteroids. Interleukin-6 inhibitors, we've been using that a lot. Studies, China, France, and the US, severe COVID-19 infections, patients in shock, respiratory failure. We've used interleukin-6. We use tocilizumab at the University of Florida. But again, some recent data, I think came out yesterday, which possibly said there may not be any benefit, but we still continue to use that. I think the larger data set needs to be analyzed before we come to any conclusions. So what about convalescent plasma? Again, this is something that's got a lot of press. So the jury is out. We really don't have any good data, but we are using that as well at the University of Florida. So thank you.
All right, Gautam, thank you very much. So that is it. That is up to the day what is going on with COVID-19. Thank you so much. It is now my pleasure to introduce to you Mickey Smith. Mickey is the CEO of an HCA hospital. It's called Oak Hill Hospital. It's a 350-bed hospital in Spring Hill, Florida. Mickey has training in healthcare engineering, excuse me, from Georgia Tech, a master's in public health, and an MBA in finance from the University of Missouri. Go Tigers. More certifications than I can shake a stick at, lots and lots of impressive organizations and affiliations. And he has been the president of most of them. So really, really a wonderful guy. Most importantly, Mickey has earned the approval and the admiration of Dr. Deborah Tracy. And I can tell you from experience, that's a hard thing to do. With that, I give you Mickey Smith. Oh, by the way, he's a Rotarian. He loves fishing and sailing, and he will tell us how COVID has affected his hospital. Mickey, please take it away.
Thank you very much. And it's not easy to, as you said, get Dr. Tracy's approval. I work on it every day.
Yes,
I want to quickly go through kind of from a hospital perspective. We live in Florida, and so almost every year, usually one or more times, we spend a lot of time planning and preparing, and most of the time it's for nothing. And that's what we do getting ready for hurricanes. And the pandemic is much like a hurricane. We're spending a lot of planning. It's like a hurricane in that some places get devastated and some places don't see it at all. Obviously, New York City's been devastated. Miami-Dade is not much better. Fortunately, in the Tampa Bay, it's been much less of an impact. But nevertheless, we plan for the worst and hope for the best. There have been three kinds of phases of planning that hospitals have been involved in. Initially, the surge plan. The initial predictions, if there wasn't the social isolation, was it was going to put a lot of demand on hospitals. And so we spent a lot of time figuring out how we could add places for patients to be. Probably the worst was getting PPE. I'm sure you have felt that. Will we have enough ventilators and staff? And this is, for all the bad things that the pandemic has brought, it certainly brought a lot of innovation and some things that I think we'll go forward with. And part of that surge planning was also putting committees together to deal with what if we didn't have enough resources to care for patients, how would we ration that? So pretty tough planning, but fortunately we haven't had to access that. We're kind of at the tail end of the second phase of planning, which looks like the governor's going to open us back up for elective cases when the ban goes away on the 8th. And so now we're trying to figure out how we're going to take care of 6 weeks of pent-up joint replacement demand and cardiac caths and all the other stuff. And it's in many ways the same kind of issues: beds and staff and PPE. And then we're the beginning phases of thinking about what's the new normal going to look like. Across the country, there's been a decline of 50 to 60% visits to ERs. You've seen significant declines in patient visits. And so what's the new normal going to look like? What are our volumes going to be? What kind of staffing are we going to need? And how are we going to change our behaviors? At least for the short term and midterm, we're going to continue with universal precaution: masking everybody, screening everybody that comes into the building, limiting visitors, and I think that's going to be the way it is until we get vaccines. If you go back to the previous slide for just a second, one of the things that the electronic medical record has done for us is give us access to a lot of big data. This diagram, which ironically looks like Chinese checkers, is a snapshot of a real-time view that I can get of my hospital, and each dot represents a bed. The color represents the patient in there. In this case, at this particular time, we had 6 positive patients. You can see how we cohorted them on units to reduce the demand on PPE. And I can see how many ventilators are being used, what beds are available, and this data can roll up through all of HCA. And so what that's allowed us to do is understand exactly where it is. We had some of the first cases at our facilities in California, and our ability to donate 1,000 ventilators to hospitals that need them will be because we have a real-time view of what's going on in our facility. So it's really helped us with the knowing what our capacity and so forth is. The second more important area of tracking right now is skilled nursing facilities. I think we're probably over the peak of people passing it to each other. I think the next danger of surge is in the skilled nursing facilities if there's an outbreak that happened in some of the southern Tampa Bay counties. And so I get tracking for all of our hospitals, what transfers have come in from nursing homes, so we can keep up with that. And then, of course, it's also useful in our clinical trials. So big data has been a huge help in understanding what's going on and being able to plan for it. Now we can go to the next slide. I've always said as a hospital administrator that I've never seen a successful hospital that wasn't surrounded by successful physicians. And so aside from the financial concerns that we face, not having elective cases and a substantial reduction in volumes while we're seeing an increase in expenses, is just as importantly, are my physicians going to survive this? We're large enough. We went out 4 or 5 weeks ago and borrowed a $2 billion from the bank to give us the cash to make it through this. But I have a lot of smaller practices that can't necessarily go out and do that. And so what can we do to help make sure that our physicians make it through this? And it's not, interestingly enough, it's not just the small practices. I have probably more concern about these large physician companies that were bought up by private equity companies. Envision comes to mind. They have $9 billion in debt, and I don't think they have a lot of assets. So with the cash flow restrictions, will these large private equity firms make it through? Maybe not. And then how do we provide a safe landing for the physicians that work there? The good thing is I've never seen the government move so fast. They've certainly made it easier to get testing done, although time will tell how accurate all of these tests that essentially where self-approved are, but they also relaxed the Stark rules, which hospitals' hands are very tied when it comes to helping doctors out, and that's been eased up in this crisis. What HCA was able to do, we went out and hired PricewaterhouseCoopers, set up a hotline where our physicians can call in and get questions answered by accountants at no charge around the programs that have been made available to help physicians with cash flow. We also have set up our physicians that have a lot of cases that require pre-authorization. You know, they may have furloughed their staff or don't have them working full time. And so we're actually doing the pre-authorizations while the Stark rules are relaxed. And for those physicians that rent medical office space from us, we had 2 months of rent relief. So the government has helped us help our physicians, and it does me no good for the hospital to survive if my physicians don't survive. Final slide. And the other piece of that is I also have to keep my doctors alive. And so safety of our patients, our staff, our physicians is very important. Very quickly, we set up as the rules around telemedicine opened up, we basically bought iPads and set up a system where physicians can basically round on their patients electronically outside of the door, not having to go in the room, and expose themselves there. So it's certainly been interesting. We've learned a lot. I think that it'll never go back to the way it was, but there will be innovations and things that make it better for physicians and better for hospitals going forward. Thank you very much for allowing me to share my thoughts.
Mickey, thank you so much. Mickey, it's wonderful to have you in our corner, because you're talking about hospital capacity, you're talking about financial aid, you're talking about protecting the physicians, and together we are so much better. And thank you. Thank you for that presentation. Next, we move on to Dr. Maulik Balani. Maulik is the Vice President of FSIPP, and he's going to review the economic impact of COVID-19 and the government assistance that's available to you. Maulik is an assistant clinical professor, Department of Neurology at the University of South Florida. He's a fellow of the American Board of PM&R, fellowship trained in pain with ABMS subspecialty certification in pain management. He's the founder and the CEO of Florida Pain Medicine, interventional pain offices in Tampa, Riverview, Wesley, Chapel, Zephyr Hills, and Brandon, Florida. And he focuses on patient care and clinical research. Not to mention, he is one of our tech gurus, just brilliant. In that case, I give you Dr. Maulik Balani. Thank you, Maulik.
Thank you so much, Jesse, for the introduction, and thank you, Carrie, for those words and knowing that the hospital administrators are, also supporting us as physicians. So they asked me to talk to you guys all about the economic impact, and every single one of our practices has been clearly impacted from an economic standpoint. So there is way too much information to cover in 3 or 4 slides like they gave us the capacity to do. So I basically turned everything into 4 fonts and microscopically wrote everything so you guys can get details. But you guys can certainly shoot me an email. My email is just mbalani@floridapainmedicine.com. I have a expanded version of everything I've written on here, so feel free to ask questions about it at the end. So a couple of things we should start with, right? All of us obviously got financially impacted, and most of us got brutally impacted when it came to the financial crisis with our practices. Normally as pain physicians, we get to bask in the glory of, hey, we don't have any emergencies, we don't take call coverage, we don't have to go inpatient, and boy, did the tides turn when it came to this, and we didn't have any emergencies, and we didn't have any call coverage, and we didn't have any inpatient work to do. So thankfully there were things available to us. I'm going to go break down a few of these for you guys. So there was the CARES Act Provider Relief Fund that came out. There was Part 1, Part 2, and possibly a Part 3 that came out. So the Part 1 basically was released on April 7th by CMS. The funds basically showed up in your practice bank accounts by April 17th at the latest. This was basically a $30 billion fund, which was released by the Department of Health and Human Services for this purpose. The grants were basically given to the providers based on their Medicare fee-for-service reimbursement in 2019. So there's a total of $100 million allotted in this account, and what they did is they took the first 30 billion, so they took the first 30 billion in there and they divided it. So they said, hey, the total amount of distributions from CMS last year were 484 billion. They said, what is 30 billion over 484 billion, and divided it. And so practices should have received about 6.25% of their total collections of CMS from last year into their accounts as an automatic deposit. Now, this is a grant. You do not have to pay the grant back. It does show up in your bank account as HHS payment, and it went through United Healthcare or the Optum Group because that's who CMS chose to partner with to fund it. You do have to do an attestation within 30 days of receiving this grant, and the attestation is pretty straightforward. Mostly everybody should qualify for this attestation, and it's simple things, not to use it on the wrong type of things, that you actually possibly took care of COVID patients, and we'll go over that in a minute as well. So this did go to the practice tax IDs, so employed physicians or independent contractors who do not directly bill Medicare under their own TIN did not receive the grant, so the grant did go generally to the practice TIN ID. Part 2 was just released on April 23rd, so 5 days ago. And what they're doing, and this is slightly different, so what they're doing is a allocation of an additional $20 billion through an HHS stimulus. So this is basically applies to only anyone that received Part 1 of the HHS Provider Relief Fund. If you did not receive Part 1, you will not be eligible for the Part 2 when it comes out. If you did get automatic funding on April 24th because you had something called the HHS Medicare Cost Report already filed, which most practices don't, hospitals may have this that they allocate, but if you did not have this filed as a practice, you still must follow the same application process. So this one's a little bit different. You do have to apply for this one. And there's about 4 criteria that are there, which I can expand on. But basically, this is also the only people that are eligible are people that have billed, or physicians or groups or surgery centers that have billed Medicare in 2019 or worked with any possible patients who have COVID. Again, this is where your accountants are going to earn their money. And so we've been on the phone with our accountants for our practice almost daily until we got most of this stuff secured. Only last week have we actually given them some time off. But this is really, really, really critical that you need to work with your accountants and have them work with you very closely. So this Part 2 is slightly different. It is going to be based on your revenue compared to year over year and how your practice has been affected. So it's going to count the losses in March and April, since it's not completed, can be extrapolated. It is not on a first come, first serve basis. So, if you file for it and you qualify and are eligible, you will get the money. The applications are being reviewed every week, Wednesday to Wednesday. You get a decision within 10 business days. And again, this is a grant. It's not there's no repayment required at all. And it's from a baseline revenue relative and a relative loss due to the pandemic itself. Now, the interesting point is that the first one was based all purely on CMS. So unlike Part 1, this appears to be linked to the overall revenue rather than just Medicare payments. So if your overall revenue was affected and you take multiple other insurances, Medicaid, and so forth, I'm not sure how that's, and I don't think anyone is sure quite yet, how it's going to affect the percentage of that 20 billion you wind up receiving. Again, you do have to submit a quarterly report after it's done. There's a part 3 that's coming up as well, which is going to be called a targeted distribution. That targeted distribution is is basically the remainder of the 50 billion, making up for the 100 billion that was granted to HHS. And they're not sure when this is coming out yet, but this will include additional stimulus going to Medicaid providers, dentists, and those who've treated uninsured patients. The other thing is the PPP loan. So if you have not gotten your PPP loan, they've obviously released a second stimulus for the PPP. I would strongly suggest you stay on top of it. You know, people don't know whether you were supposed to submit this directly through the SBA or whether you work through the banks and so forth. So, you know, you have to work through the bank. And the way this was done is basically this was a paycheck protection program that was only there for keeping your employees employed. So, you know, you want these staff to stay on with your practice. You have till June to get them all back on staff. And it's basically a loan that can be forgiven, but it is a loan. So if the portions that are not forgiven will need to be repaid at a 1% interest, and that has a maturity of about 2 years. Again, what I would encourage you is to work with your banks. If your banks are not, if your bank is not submitting any more SBA loans, you can work with small banks. Small banks actually usually have great relationships. They know your value to the community, and they want to work with you. We were fortunate enough to receive these just less than a week ago, actually. And so we went through our business bank, which was SunTrust, and you know, people have a lot of frustrations with, you know, communication from banks and getting this money as well. But again, you know, this money was meant to be redistributed to the practice and keeping your employees employed. So 75% of it can be used to go back to your employees. 25% of it can be used to offset things such as rent, utilities, and help you with overhead costs. The EIDL was basically the economic injury disaster loan, and it was up to 10,000. Again, it is a forgiven grant. You can apply about 1,000 of it per employee, and unfortunately, this has ran out of money as it is. The last one that the government released to us was the Medicare advance payment. And so with regards to Medicare advance payments, you know, as of April 26th, so just 2 days ago, they're not taking any more applications for the Medicare advance payment. It is unclear if there will be more funds available at a later date, but let's all hope so. But basically, the CARES Act dictated that CMS may release an advance payment to your practice, which allows you to get 3 months worth of Medicare payments that will get released to you almost immediately. This is, again, to help you float the practice, cover overhead. Now, again, this is essentially a loan. And so what happens is, the way it works is, from the day you get it, you have about 120 days that you can go ahead and continue to bill CMS, and CMS will continue to pay you. The remainder days, so from the 120-day mark up to the 210-day mark, is when the recoupment of these funds will start happening. And so, you know, you can ask for an extension at that point if you want to prolong it past the 210-day mark. It is a high interest loan at that point of 10.25%. But again, if you need it and you need the cash flow, you can absolutely do it for your practice. Next slide, please. Next slide, please. Thank you. So there was a couple of other available resources to us locally. The Florida Disaster Relief Fund was there. That actually was 50 million, and that ran out very fast. You know, we did apply for it. We had no communication that we received, and you know, that was a state fund that was available for any businesses that were impacted within the state of Florida. And I put a link there as it is. So are they going to have a second funding? I'm not sure. The other ways you guys can all look at, how to help your business survive, and we've implemented almost every single one of these things at our practice, is talk to your medical malpractice premiums company. So, initially they were allowing for delays and up to 9 months of deferring payments, but now what they're doing is discounting the next 3 renewals. But again, each company is slightly different. So work with your medical malpractice premiums companies to see what offers they have available to you. Again, this is where your accountants are going to earn their money for 2020. Okay, employee retention tax credits and deferral of employer payroll taxes. Both of these are benefits you can use, especially if you did not receive the PPP. The employee retention tax credit may be something you really want to consider utilizing. So basically, it takes your employer taxes and lets you either defer them or use a proportion of them to be forgiven, so you can pay your employees, but then you don't have to pay those employer taxes down the line in order to go ahead and help your practice from a financial standpoint. Now, thinking about the other side, not just you as physicians or practice owners, you also got to think about your own employees. And this has been an uphill battle, not only at our practice, but several other practices, because short term right now, the state of Florida, if you're unemployed within the state of Florida and you qualified for unemployment benefits, you could receive up to $850 a week for being unemployed. And so, and that's through July 31st. And so, the issue becomes that a lot of these employees may actually make more money being unemployed rather than employed. So even if you got the PPP, and you'd laid them off and they had claimed unemployment and started receiving it, may say, no, I don't want to come back till July 31st, which hurts you from a practice end, because now you have to decide whether you're going to use that money as a loan or, give it back. But again, just think about your employees as well while you're doing this. We've been fortunate enough to retain almost every single one of our employees and bring them back. We brought them all back full-time Thursday. Lastly, a couple of other avenues you can look into is changes to your retirement plans. There are retirement plan redistributions, which are now being allowed under the CARES Act as well. And so what this allows you to do is basically take a distribution from your retirement without necessarily having to pay penalties on it. Penalties such as, your ordinary income tax, your interest on it, or anything like that. Now, they do have to be replenished at some point, but I believe they're giving up to 3 years for a lot of these restructurings. Again, work with your accountant. If you have a certified financial planner, they may be able to guide you through this as well. And student loan assistance. I know myself, I have student loans still that are out there. And so, as an employer, you can actually help your employees or your employed physicians give a chunk of it, up to $5,250 back to your borrower, and this is again tax deferred. So most student loan assistants have actually deferred automatically payments for 6 months as well. So, and there's lots of other freebies out there as well, right? So the recovery rebate checks, we probably won't qualify for these, but if you're a resident, a fellow, you certainly will qualify for these, and you should look into it. These are based on your adjusted gross income per year as a single or as a family. And then, there's lots of discounts out there for we never get free stuff as physicians usually, other than the hospital cafeteria. So, now what it allows you to do is get lots of free stuff, right? So I've put a link on there. It's a website called slickdeals.net. But if you literally go on there and just, search healthcare worker discounts, you'll see a list of lots of things that pop up that are eligible for you. And lastly, one of the things you may want to look at is also just home deferment. Mortgages. We've been able to defer our mortgage for 3 months and extend it up to 6 months, where there's no payment for your mortgage, there's no penalty, and all they're doing is, instead of making it a 30-year loan or a 15-year loan, they'll add 6 months to the tail end of that, but there will be no interest charged at all. As it is. And again, each bank is different. So thank you guys so much, and we'll certainly be around for questions later.
Malik, thank you so much for that. That is so helpful, because many of us are struggling financially. That is a wonderful summary, a wonderful expose of all of the options that we have. from saving money to getting money from the government to earning money for our practices and keeping our employees. Thank you. Guys, I just want to say something about questions here. So if you have a question, we have a chat box and it's on your screen. Just write your question in the chat box. That question comes to me. I'm going to distribute those questions to all of the speakers after everybody is done. But in the interest of time, we're going to move from one speaker to the next. Please send all your questions in. They're wonderful. We want them. Also, all of the slides are going to be available to everybody after the webinar. So for example, that link that Malik put in his presentation, you'll be able to click on it. So that'll be good. Next, we're going to move on to Attorney David Vaughn. David is going to cover the new COVID-19 regulations for pain management practices and for much of procedural medicine in Florida. David is a prolific author, having written many of the billing and coding manuals that we use in our daily practice. He defends doctors in multiple disciplines from state and federal prosecution, key TAM cases, for any of you who don't know, that's the whistleblower cases, Medicare or other third-party carrier audits. David is trained at Mississippi State and LSU Law School. He's really our go-to guy for many of the FSIPP questions that involve practice law, billing, and coding. He's just marvelous. With that, I give you David Vaughn.
Thank you, Jesse. It's a pleasure to be here with you guys this evening. It's thundering where I'm at, so if you hear some thunder in the background, that's what it is. So for the most part, I'm going to discuss today how to keep the money that you have from the various programs that have been delivered by the federal government. So if we could go to the first slide, please. So the Payroll Protection Program, the PPP program that Malik talked about, there's a forgiveness piece to that. And so what I want to focus on is, okay, I've got the money, and just so for you guys to know, the PPP program wasn't specific for physicians. It was for all small businesses primarily. I applied for a loan on behalf of my law firm. We got that loan. It was a nightmare to go through the hassle to get the loan because nobody knew what they were doing. The banks had to come up with their own system. Every time I submitted my documentation, their lawyers and the underwriters would come back and tell me they needed something else, and it wouldn't even be in the statute. It wouldn't even be in the regulations, but we had to just do whatever it is that they wanted us to do in order to get the loan. So now that I have the loan, how do I make sure that I spend the money appropriately and I don't have to give a bunch of it back? Because that loan turns into a grant if you use it for specific things, but only for specific things. So the things that you can use, and by the way, the first recommendation I have is you got this money, please put it in a separate segregated account, because you're going to have to prove to your bank what you spent that money on. And if you have it in a segregated account like we did, we opened up a brand new account, put the money in that account so that everything that comes out of that account, it's not commingled with my other funds in the law firm. It's strictly in that particular bank account. So I can prove how much money came out of those dollars for payroll, how much came out of those dollars for mortgage interest, rent, utilities, etc. So assuming that you've got the money segregated in a separate account, you can spend it on payroll. Now, you get to deduct the entirety of the payroll with a couple of exceptions. Any of you, all of you, I'm sure, make more than $100,000 per year. I make more than $100,000 per year, so I reduced my salary to $100,000 per year, so that what comes out of that segregated account for me is just $100,000 a year. Whatever else I make comes out of a distribution in a separate account, but the PPP program is paying its portion of the $100,000 for me. So I can count that full $100,000. In addition to that, the taxes that come out of that are also can be in addition to the actual salary. So if you take $100,000 divided by 12 months, it's like $83.33 a month. So in addition to that $83.33 a month, I can also include as part of that forgiveness my deductions from my HSA account, my retirement account. Whatever is taken out, my actual payroll taxes. The only thing that you can't take out of that is the employer's portion of the payroll, which is it's 1.45% of the Medicare matching, and it's 6.2% of Social Security. So it's about 8% ballpark, 7.5 to 8% that you're going to have to give back if you pay it out of that PPP account. The second thing is that you can count is mortgage interest, not mortgage principal, mortgage interest. So you'll have to have your accountants to segregate that. The payment will just be a lump sum payment. I mean, you're not going to separately send in your interest as opposed to the mortgage principal, so you'll have to segregate that out. One of the interesting things that I saw in the statute was that you can deduct rent, but rent is defined, and rent is defined as a lease that existed prior to February 15th. So that's all the guidance they gave us. So in my personal situation, I got all kinds of rent. I have rent on my office building. Okay, well, I'm assuming I can count that. I've got rent that I pay to a storage unit. It's like $530 a month, where I have like 2 or 3 storage units I lease. Well, can I pay that? Not sure. I'm going to, and then I'll submit it to my bank to see if they approve it. And then I've got all other kinds of leases on equipment. I got copiers, I got fax machines, I got equipment leases. I'm sure you guys might have C-arm. So we're not sure whether or not rent, the banks will allow us to deduct that as part of the forgiveness. I'm going to pay it because the bank, your individual bank, and it could be different, my bank from your bank, but each individual bank will determine, and they are held harmless by the feds from this determination as to what part of the rent that you pay is forgivable. So they may say, David, sorry, the only thing you can deduct as rent is the actual rent on your office. You can't deduct the equipment lease. Or they might tell me you can deduct it all. So we'll just have to see on that. Currently, there's no guidance on that. Next, no more than 25% of that money in the PPP account can be used for non-payroll. Well, that's the items that we just listed above there. So up to 25% can be used for the mortgage, interest, rent, utilities, and other items. I think most of us can meet that 25% threshold. Expenses are forgiven for 8 weeks after the loan. Now, this is an interesting thing. So for me, when I got my loan, I was right in the middle of a payroll period. I only get 8 weeks, and the 8 weeks start not from the date that you make the first payroll, but from the date you get the loan. So I had to wait a week before I made my first payroll. And that ends up costing me in the long run 1 payroll period, because I missed a week. So now I only have 7 weeks instead of 8 weeks because I got the money in the middle of a payroll period. So one of the things I'm thinking about doing is going to my payroll company and telling them, I don't want to pay every 2 weeks. I want to pay every week. So I'm going to do that, where I start paying every week. And that may be something that you might want to think about doing as well. Wages have to stay at 75% of the pre-loan amounts. So what that means is if you reduce somebody's salary by 25% or more than 25%, you have to deduct that amount. So I was talking to one of my clients today. She had been put on furlough. She came back, and now she's making 50% of what she was making before. As a result of that, that employer is going to have to, they can get away with 25% reducing, but not the 50%. So 25% of that 50%, they're going to have to be penalized for, and that part will not be forgiven. Then the number of employees. Your loan forgiveness will be reduced if you have less employees at the end of June the 30th than you had prior to February 15th. So in my case, for example, I laid off a girl that was not producing very well for me. I laid her off before February 15th. I laid her off after February 15th, but I laid her off because she wasn't doing a good job. But I'm going to be penalized for that. So even though I've kept everybody else, I'm still going to have, let's just say I have 10 employees, and now I have 9 employees. So the $150,000 that I got, 15,000 or 10% is going not to be forgiven because I only have 90% of the employee volume that I had before. So that's the practical way of how you will be penalized for no fault of your own, just because you have fewer employees. Okay, next slide, please. All right, so the relief funds, Dr. Milani spent a good time talking about this, but what I want to tell you is a different phase of these relief funds. So he told you that we have two buckets of relief funds. We have the $30 billion that just showed up in your account one day, and then we have the $20 billion that's new money that just came out, for which you have to file online a separate application to get that money. But to keep that money, you have to attest to certain terms and conditions. And when those terms and conditions came out, there was a good amount of angst about what they meant, because one of the terms and conditions was that you had to actually provide diagnosis, treatment, testing, or care for actual or possible COVID-19 patients. And a lot of the pain doctors were saying, hey, we didn't do that. I didn't treat any COVID-19 patients or people that I thought were COVID-19 patients. So to clarify that, HHS came out a couple of weeks later and said, we consider all patients as possible COVID-19 patients. So that means that you can legitimately attest to the terms and conditions which the primary term and condition that you treated actual or possible COVID-19 patients. So that was a big help that the government provided clarification on. Now, one of the things that you have to attest to is that the payments will only be used for expenses and lost revenue due to COVID-19. So again, one of the things I'm recommending is that you take that money, you put it into a separate account, not an account where the PPP money is, not an account where your regular checking account is, but in a separate segregated account, so that you can prove that that money that you got out of that 30 billion and subsequently the 20 billion was spent for expenses and lost revenue for legitimate things. Now, the funky thing is that they don't tell us, here are the legitimate things. What they tell us is, here are the illegitimate things that you cannot spend the money on. And I think most of you will be able to attest, you're not going to spend it on pornography, you're not going to spend it on gun lobbying, you're not going to spend it on, there's a whole probably list of 10 different things that would, abortion, a list of things that you typically would not spend your money on anyway. And so I feel like that most of you will be able to attest and affirm that. If you cannot attest to these things, you have to go to a portal and pay the money back, even though you got it. Because if you do not, the government has stated that if you don't pay the money, then by law, you have constructively attested to the accuracy of keeping that money. So you can't just keep the money and say, oh, gee, well, I didn't attest to anything. No, you have attested even though you don't attest. So if you cannot meet the attestation, the burden is on you to go there and pay the money back. Now, one of the things I wanted to mention is this next bullet here about executive level 2 salaries. So an executive level 2 salary, you can't pay more than an executive level 2 salary with this 30 billion, your portion of the 30 billion or your portion of the 20 billion. That level salary is $197,400. So if you got PPP money, which allows you to spend up to $100,000, this now allows you to spend up to another $97,400 for each of you that make more than $100,000 annualized over 12 months. So ballpark, you're making $8,300 a month from the PPP. Ballpark, you're making another $8,000 a month from the HHS Relief Funds. So collectively, that's about $16,000 or so each month that can be covered by either the PPP or the relief funds. Again, if collectively you have made more than $150,000 out of all these government programs, PPP, HHS Relief Funds 1, HHS Relief Funds 2, you have to file reports. And they will audit you on those reports. They can. As a matter of fact, you have to fill out an attestation now that says, hey, I agree to be audited. I want to briefly mention this new $20 billion application. So there's a couple of things I've done that you guys might want. My email is david@lalawfirm.net. The first thing that I did is for this $20 billion, if you could go back, please. For the $20 billion, you have to go through about a 20-step process online, and there is a guide that they put out, but that guide doesn't turn into a PDF. So I took snapshots, I took screenshots of every page, and I turned that into a 28-page PDF that explains exactly how you fill out everything that you need to fill out for the $20 billion. If you want that, email it to me and I'll shoot you the guide in one nice, neat PDF. On the previous slide that we just looked at about the PPP loan and forgiveness, there was an accountant who put together an Excel worksheet that walks you through how the forgiveness works. If any of you want that Excel spreadsheet, I'm happy to email you that as well. Okay, next slide, please. So you would think that the government, being tied up with all the COVID-19 issues, wouldn't have time to go after Florida pain physicians for False Claims Act, but that's not the case. What still remains prevalent in the government's eyes is urine drug testing. For those of you that have an analyzer, that have a high complexity lab, especially if you have a high complexity lab. This particular Florida pain clinic just settled a case with the government to repay $41 million for overutilization, allegedly, according to the government. And what I really wanted to warn you is that the government data mines your billing. So what they have done in a number of cases, and I've talked to auditors who have confirmed this with me, is that they will go to 80307, which is the CPT code for a screen, and they will go to G0480 through G0483, which are the G codes for confirmations. And if the number of screens equals the number of confirmations, that means you're confirming every single screen. And now that's called a 1-to-1 ratio of screens to confirmations. It is the government's view you don't need to confirm every screen. And so if you have a 1-to-1 ratio of screens to confirmations, I recommend you back that off. I don't know what that magic percentage is. I typically tell most of my clients, hey, try to stay below 75%. So if you've got 1,000 screens, only have 750 confirmations, but I'm guessing. I don't know what that data mining number cuts off at, but I do know the 1-to-1 ratio is pretty much a surefire way to get audited by the government. So please make sure also that when you order the confirmation, you do not do it automatically, that you look at the screen results first before you order the confirmations, because the government is convinced that you will not order a confirmation every single time if you look at the screen results, because it may not be necessary. So they want that confirmation to be individualized based on the patient and the screen results. With that, thank you very much.
All right. Thank you, David. Thank you for that presentation. I think that one of our first rules should be we don't go to jail. And thank you for telling us how to stay clean and productive. Next, I'm going to give you Dr. Miguel de la Garza. Miguel is the president-elect of FSIPP. So he's going to take over the reins this coming July. I have known and worked with Miguel for the past many years. He brings heart, intelligence, and dedication that's going to carry our organization into the future. I am hoping that all of you will be attending the FSIPP annual meeting in July. It's going to be in Hollywood, Florida, at the Diplomat. It's going to be the best pain meeting of the year, and that's where you can see Miguel come in to be the president. Miguel has a bachelor's degree in molecular biology. He has another one in chemistry, board certifications in pain and addiction, specializes in minimally invasive surgeries. He loves to spend time outdoors, fishing. He is on the executive board of directors of the Boy Scouts. This guy is amazing. I give to you Dr. Miguel de la Garza. Miguel, we cannot hear you. You're muted. You're muted. No, can't hear you.
Miguel, you're unmuted on our end here. Check your computer directly. Miguel's background looks amazing, but it looks like he's going to come directly on a headset.
Okay, guys.
There you go. We hear you.
That's it,
You're
Miguel.
on, Miguel.
Can you hear me now?
Yes, we've got you.
So. Okay, so we're going to go to plan B, and that's why I always have a backup. So what we're going to do, I'll just speak very loud, and I'll just talk very quickly. As you may know me, I tend to do that anyway. So we're going to go over some key elements here of the telemedicine review, some COVID-19 emergency orders that came into existence very quickly after this was identified as a potential threat to the United States. We also want to review some telemedicine and CPT coding guidelines that come down the pike. They were changed several different times and have been refined by HHS, and also the AMA has provided guidance on these particular things. And we have the simplification for most people within their practices, if they're in the outpatient setting, to essentially bill these appropriately and get paid at 100% of what you would have been getting previously in the outpatient setting by doing telemedicine. We also want to review some of the necessary elements for the SOAP note for that particular telemedicine to make sure that you are compliant, and also to make certain that you are able to receive that remuneration from all of the carriers, not just HHS. And we also want to go over the best practices and approaches for determining the face-to-face versus doing a telemedicine visit. And this may be most important, especially after phase 1 and phase 2 and phase 3 happen as released by the White House, and what to do with re-implementing not only seeing patients face-to-face, but also doing surgeries that are elective that here to previously would have not been allowed to have happened. Next slide, please. Next slide, please. Thank you very much. So with telemedicine, can you go back one slide? I think we missed one. So on March 6th, an emergency order was passed by Medicare and HHS that would allow all physicians to be reimbursed, provide clinical telehealth services for all beneficiaries regardless of their location. This is very, very important because previously, these patients receiving telemedicine was specifically designed for rural areas. In those patients would have to go to a specific rural site and receive a face-to-face telemedicine via a specific conduit. Now, all Medicare beneficiaries, either in the rural or in the metropolitan areas, are eligible to receive telehealth in all facilities. That includes nursing homes, that includes assisted living facilities, that also includes in their particular home at the specific time. And the reason that the government is allowing this to occur is because they want to reduce the risk of exposure to someone who is either ill or may be potentially ill, especially if they may become or may be an asymptomatic carrier. Next slide, please. The temporary 1135 waiver specifically allows new and established patients to temporarily be eligible for all services. This means that even a new patient consultation for a patient who may be coming to your office would be able to be seen if they are in an assisted living facility and are on lockdown, or may also potentially be in their home. You can see them as a new patient. And this is not only specific for physicians, but nurse practitioners, clinical psychologists, licensed social workers. The other important thing is that you do not necessarily have to be licensed within the state where the telehealth services are being rendered. Specifically, the barrier between one state and another was lifted such that even in the most rural areas, a physician or a nurse practitioner or a psychologist could render services for a patient, especially if they need to be seen, to limit the possibility of COVID transmission. In addition, Most, if not all, audiovisual services or applications are allowed to be used, including FaceTime and Skype, that heretofore were not allowed. This is a temporary lifting of these specific guidelines, and HHS and CMS wants you to make a good faith effort to ensure that patient confidentiality is protected and that all encryption standards are followed within that particular application. All health services are going to be paid at the in-person rate, and your note should reflect that the 1135 waiver is being utilized. And we'll go over some specific elements of those particular things in your note and how to document that. Next slide, please. Specifically, the CPT coding is a little bit different than it would be otherwise. And this has gone through several different iterations, but these are the finalized ones that we'll present. Telehealth visits are payable by Medicare. The evaluation and management services, i.e. office visits, specifically use CPT codes 99201 to 99215. Audiovisual visiting visits that replace the office visit for new and existing patients can be utilized. In addition, a virtual check-in where a patient may go to a virtual waiting area can also be billed, but at the G2012 coding. This is very important. This is probably where this may specifically apply to most physicians. Physicians who bill telehealth services using the place of service indicator defined in a practice, specifically in the physician office, is site of service 11. The outpatient hospital campus is 22 code. The telehealth, if you already had a pre-existing telehealth practice and there is no specific site that you're seeing patients, should bill a 02. You then need to indicate that you're utilizing telehealth by providing the 95 modifier and all claims that are being described and are being furnished via telehealth. Next slide, please. Just to reiterate that point, it's very, very important. All outpatient practices, if you see a patient via telehealth, bill the POS 11 and append with the 95 modifier, and you will be paid at the office rate that you would have been paid heretofore prior, and not at the lower facility rate that may have happened prior to these specific modifiers and that bill POS site being billed. So that's very important, and please keep that handy and give it to your biller if you're not doing that now. Thank you. Next slide. It's very, very important also to understand that each Medicare Advantage plan has their own standards, and those standards will be published on their website. You may literally have to call some of the HMO plans and basically argue with them that you are providing care to patients and it's not possible for them to come to the office, and in which case you would make the case that CMS is following the standard, and they should too. Commercial carriers are highly variable, and you need to confirm prior to seeing the patient that number one, it's a valid service within that patient's plan, and number two, that they have a specific coding guideline in which it will allow this to occur. It is important to note that Florida Medicaid does follow CMS guidelines in this regard. However, it would be at a reduced rate. Next slide, please. Is this state specific? Providers must have a license in the primary state. The requirement to have a license in each state where the services are being rendered has been temporarily lifted, but you must understand that each state may have superseding guidelines that are more restrictive than those of HHS federally, specifically when prescribing opioids. You may have to default to the state standards in which that case may be occurring, especially if it's across state lines. Next slide, please. What is the actual case for the state of Florida? During this public health emergency, practitioners may issue prescriptions for controlled substances to patients for whom they have not conducted an in-person medical evaluation. Specifically, they can provide opioid prescriptions to legitimate patients for a legitimate medical purpose by the practitioner who is utilizing this in the usual and customary course of the professional practice. The telemedicine communication is conducted using an audiovisual, real-time, two-way interactive communication system. Practitioner is following the applicable state and federal guidelines, and in this case, an in-person medical evaluation of the patient does not have to occur for a controlled substance prescription to be issued to a patient via telemedicine in the state of Florida at this particular time. Next slide, please. So the bottom line is, from multiple societies and from government regulations, is that you perform telemedicine for most, if not all, high-risk patients, and most Medicare patients, based upon their age and multiple comorbidities, and potentially also because they're being prescribed opioids, fall into the scenario where they will be high risk. Face-to-face patients should, if you have to see a patient and it needs to be in a facility or it needs to be in the hospital or even in your office, you should provide the social distancing, especially at 6 feet. You ought to wear a face mask. Hopefully it will be an K95 or equivalent N95. And also wear gloves if you have to examine a patient, but at this time, it's even recommended that not examining patients may be potential. Before that patient walks into your office, however, you definitely need to run through a questionnaire about this particular patient, following the CDC questions about whether they are symptomatic or not. Even though it may be possible that asymptomatic patients may walk through your door, it does not necessarily mean that they would not be seen, especially if there's an acute situation that requires you to evaluate them. When determining the telemedicine components for your specific SOAP note, essentially these are the same as you would do with a face-to-face note. However, you do need to tell those particular insurances that you were billing that, number one, a telehealth visit did occur, number two, the reason for the telehealth visit, and you also need to provide consent, at least verbally, from the patient at the time of the encounter that you're going to do it and the reason potentially why you were doing this. For example, you may say, I personally conducted a telemedicine visit via Skype due to the state of Florida and federal guidelines applicable to COVID-19. Explain the reason and rationale to the patient. He or she expressed understanding that this was in place of a in-person visit. Next slide, please. So this is a list of HIPAA-compliant video communication published by CMS. As you can see here, Skype, Microsoft Teams, Zoom for healthcare, DoxyMe, Cisco Web Meetings, Amazon Chime, GoToMeeting, and Spruce Healthcare Messenger are some of the pre-existing solutions that are already on the market. Next slide, please. It's important to note that these had specific levels of encryption and also had a published business associate agreement with Medicare that allowed these to occur. HHS has temporarily approved Apple FaceTime, Facebook Messenger, Google Hangouts, Zoom, and Skype. But you do need to notify these patients that these are third-party applications that may have specific privacy risks. If you're going to use these, please enable all of the encryption and privacy modes that are possible for these particular certifications. In addition, if you have to perform a phone consult because the patient does not have the capability to use these particular technologies, that is also okay, especially if you're doing it in good faith with your patients to make certain that they are safe. Next slide, please. Prohibited applications, Facebook Live, Twitch, TikTok. These are all publicly facing and should not be used for seeing patients via telehealth and are specifically listed in HHS as not approved. Next slide, please. These are some resources that would be very beneficial for you. Next slide, please. These are some of the references that I used. At the end of this particular slide set, I also have more slides that may be applicable to your specific situation, specifically in regard to spinal cord stimulation, programming, intrathecal pumps, and also billing, coding, and requirements that are published by the AMA. Thank you very much.
Miguel, thank you so much for that. We are up to date on telemedicine Thank you. For anybody who's listening to this webinar, the entire webinar will be available on the FSIPP website after this webinar, and you can access any of it for all the information that's being presented. We now go on to Dr. Harold Cordner. Dr. Cordner, Harold, is a past president of FSIPP. He is the current president of ASIP. He will discuss recovery and getting ready to reopen your medicine practice. Harold is trained in anesthesia, subspecialty in pain medicine. He's an associate clinical professor at Florida State, and he's one of the editors of Pain Medicine and Neuromodulation. Harold has been in practice in Vero Beach more than 20 years. It's been my pleasure to serve with him on the FSIPP board. He is always the go-to guy when we have tough questions. The reason? He's level-headed, he always has a long-term view, and he has the very highest level of social and academic intelligence. With this, I give you Dr. Harold Cordner.
Thank you, Jesse, for that lovely introduction. So we're going to talk about getting back to normal. We're all been quarantined and not being able to practice, but it looks like probably in the next few weeks, Governor DeSantis is probably going to let us go back to doing some elective cases and level 1. So Trump talked about open up America again, and we talked about phase 1. Sorry, next slide. Not working. There we go. So the proposed phase is going to be 3 phases for that. Next slide. Next slide. And one more. What that affects us in here in this phase 1 is schools, organizers, but here elective surgeries. So fortunately for pain physicians, in the phase 1, we will be able to reassume elective surgeries. Governor DeSantis has assigned a task force to talk about this, and they're supposed to make the recommendations last Friday, but they did not. They're scheduled to do that on Thursday of this week. So Thursday of this week, hopefully we'll have an answer on when we'll enter phase 1 and elective surgeries will be allowed. And this is kind of about how we do that. Next slide, please. So as Winston Churchill says, a nation that forgets its past has no future. So certainly we have learned a lot from this COVID situation, and we will begin here. So 2 things that when we look at the state things that when you can enter phase 1 certainly is when the number of cases has declined for a period of 14 days. So each state and even in the states, they may govern that. For instance, in Florida, there's a good chance that South Florida will not go into phase 1 before some of the other counties or the rest of the state does. And then hospitals, this is really indicated because we wanted to make sure that there's a robust testing program available, as well as enough PPE to support the hospitals. Next slide. And again, the same thing there. We're talking about that we have enough ability for the healthcare system to have enough ICU beds, PPE, and once they have that confirmed, then you can go into level 1. Next state. Okay. So part of the reopening is going to be antibody tests. And so we now have several antibody tests that have been approved by the FDA. And so with more testing available, we will be able to reopen. We are going to have to test not only employees, and remember this has to do not just with our practices, but with hospitals. And you're also going to have to test patients. And so we certainly need testing to proceed with opening up and proceeding safely. Next slide. Next slide. So the CDC, go back one. Back one. There we go. So online, you can see the CDC has different, no, too much. There we go. The CDC has written guidelines. You can look at, this is actually a picture online of their return to work for healthcare personnel. So if you have personnel that have been confirmed or suspected COVID or were exposed to COVID, they go through how to do that in great detail about testing and how long you have to wait. I'm not going to spend too much time on that because it's listed there and you can look that up on your own. But the next couple of slides, I included all this on the slide so you can download this from the website from FSIPP, or you can get them from me directly, and all the things are on here. So the next slide kind of goes over this right here. There's decisions about return to, and it either be a test-based strategy or a non-test-based strategy. Next slide. And again, test basing is either going to be looking at nasal swabs, looking for antigens for 2 consecutive nasopharyngeal swabs 24 hours apart, or a negative serology antibody testing. Next slide. Next slide. And again, here we go, return to work practices. These are for your employees who have been exposed to COVID or were suspected. Next slide. Go back one. There we go. And again, this is, go back, whoever's controlling that. Back one. All right, go forward now. Sorry. Forward. One more. There we go. Okay, so this is recommendations for patients with suspected or confirmed coronavirus disease in healthcare settings. And again, these are guidelines by the CDC that are downloadable, and they're on this presentation. So if you have patients that you're in high-risk areas or patients that have suspected or confirmed COVID, these are guidelines for seeing those patients in a healthcare setting, which includes our offices or ASCs or wherever you're doing your procedures. Next slide. So again, key concepts. This is kind of a brief summary. You want to reduce the facility risk. So this is kind of important. You should be doing this every day anyway, whether you have negative patients or not. But using telemedicine when you go back, you should be using telemedicine during the phase 1. Still, you want to reduce risk to your facility, to your employees. So continue telemedicine even if you get into if we get into the phase 1, limit points of entry, manage your visitors, screen everybody coming in like you're hopefully doing at this point. Don't change anything as far as that goes during your phase 1. Continue reducing that risk. Isolate symptomatic patients. So if they're symptomatic, you need to get them into an area where there's no other people around and either test them further or have them go to the hospital or the doctor's office. And again, protecting your healthcare personnel with masks, limiting their things, limiting their contact with patients, using hand sanitizer, et cetera, et cetera. This common sense things that we should be all be doing. Next slide. And again, how do we decrease risk of morbidity related to COVID in our pain patients? So ACIP put together a task force with those people there listed, Dr. Shah, Dr. Dewan, Dr. Soin, Dr. Garibo, and Dr. Raju. And they came up with some stratification guidelines for return to pain procedures. Now, this is a fluid document. In fact, it changed today from last week when it was presented. I have the most up-to-date stuff that was about an hour ago that we changed some of the guidelines here. So no one's seen this yet except you. And this may change in the next week as things change. It is a fluid document. So next slide. So vulnerable individuals, obviously elderly people, where we have in Florida, most of our patients are in that things. but individual serious underlying health conditions. So we see all these are all risks for COVID and for complications from COVID. Next slide. So this was the current or the previous guidelines that were printed out on the ACIP website as well as at the webinar. So if you saw that, this was current about yesterday or 2 hours ago, but we have changed this, and I'm going to highlight some of those changes. So on the top, where it had ages, that a high-risk patient was over the age of 65, and that in and of itself was an independent high-risk factor. We have modified that. So next slide. So currently, if the patient is over the age of 65 and is a resident in a nursing facility, assisted living facility, or incarcerated in the past 30 days, they would be considered a high-risk patient. So in those tables, if you look at the risk factors that are listed on the left-hand side, and then you have low risk in the first column, moderate risk in the second column, and high risk in the third. Each of those risk factors carries a point factor. So if you look at low risk, each of those risk factors is 1 point, for moderate risk is 2, and high risk is 3. And so on the bottom of that chart, you'll see a low risk would be greater than or equal to 7, less than or equal to 7 points, moderate risk from 8 to 13 points, and high risk would be 14 points or greater. So based on the risk stratification that you see your patients, they would fall into one of those risk factors of low, moderate, or high risk. Next slide. And so this is kind of what it looks like now without the risk factors there. Go to the next slide. Here we go. So this was the original flow chart for dealing with patients on whether they had COVID status known or not. And if you follow going down from COVID status known, no, and then you put them into a risk category. At high risk, it basically said to delay procedure and test the patient for COVID for 2 consecutive swabs before proceeding. We have changed that. Next slide. And so whether the patient is moderate or high risk, basically the statement is going to say that you recommend that you have an assessment with the patient and discuss the risk and decide whether to proceed or not, and then to consider COVID testing in those patient populations. There's also a disclaimer on the left, basically that talks about these are guidelines, they're not standard of care, and that the ultimate decision should be left up to the patient and the physician to talk about those risks. So the guidelines are fairly flexible, and this is very difficult to write guidelines for this when you have people in New York City versus patients in rural Wyoming or Montana. So those are the current guidelines as of an hour ago. They may change again as things change if we find out phase 1 is not working so well, or we have people putting in complaints or suggestions. Those guidelines will be revised as needed. So these are some frequently asked questions. I won't really delve into those to save time. But they're pretty common questions, frequently asked questions that people ask, with questions about how to open, what should we do about these things, should I start seeing patients, and those are pretty well done by evidence-based medicine. One of the things that I highly suggest in this form, you can download from the website, or you can get it from me if you email me at gassdoc, gasdoc with 2 S's at AOL.com. This is a consent form that also includes wording and verbiage for confirming that the patient is an urgent procedure. We were using this during the ban on non-elective on elective procedures for urgent cases that had to be done. So it should protect you from doing those cases during phase 1 or presently, but also there's some consent and release about doing procedures during COVID and using steroids. So take a look at that. It's a pretty good document. Next slide. Those are references, and again, those are available if you want to look at them. Next slide. The end. So thank you very much for your attention, and if you have any questions, save them for the end and be happy to answer them. Thank you.
Harold, thank you so much. Talk about up to date. Wow, we are within 1 hour of the changes. Amazing. Thank you.
You're welcome.
All right, we now go on to Professor Renee Priscora. Renee, we are very fortunate, is on our board. He is the current president of the Association of Pain Management Directors. So Renee is the go-to person when it comes to training the next generation of doctors. He's the director of the Pain Fellowship at University of Florida. He is a professor of anesthesia and pain management. He trained in Germany initially, got an MD from Wurzburg, got a PhD from Bonn. He trained as an orthopedic surgeon. He went on to anesthesia. He did pain fellowship at Harvard. This guy is smart. Then he got an MBA. Many peer-reviewed publications in pain management, runs a large research project at UF, and he's the editor for the American Board of Anesthesia. Guys, we are very fortunate to have Dr. Renee Priscora. Renee, please take it away.
Hey, Jesse, thank you very much for the lovely introduction. Greetings from the Gator Nation here in Gainesville. Good evening, colleagues. So we'll talk about the impact of COVID-19 on the fellowship training. And of course, there is an impact, and it affects fellowship programs at various aspects. I think we can move to the next slide, Michelle. And I think the main aspect is basically the decrease in patient volume, the inpatient visits, and of course the procedures due to the different stages of the lockdown nationwide. And there's especially concern regarding the lack of hands-on experience for fellows in terms of interventional pain procedures, implants, and minimal invasive surgeries to treat pain. Now, already alternatives have been developed and are currently implemented, including like tonight from FSIPP, like webinars. And also please consider that the fellows coming out of this year's academic year are trained in, most likely will be trained in telemedicine, which to be fair, the previous years, we have not trained our fellows in telemedicine. So they're going to be ahead of the game. Now, how is that all going to play out long term or in the short term? You know, of course, COVID-19 interferes with the fellowship training, but luckily of all the crisis, because the pandemic has affected the last quarter of the fellowship year, I think, and what I hear from my colleagues, you know, I'm the president of the APPD, is that the effects are currently well mitigated. We're also in discussions again with the ACGME and with the pain boards, the ASA and PM&R boards, you know, that our fellows stay on track with graduation. We do anticipate there will be maybe administrative delays or alternative pathways for the crisis. However, I can give you the personal feedback. I think that the pain medicine fellows, despite COVID-19, are very well trained. So if you are considering hiring a newly graduated fellow, somebody coming out fresh out of training, please do not hold the pandemic against them or question their training level. I would just do the usual approach you have done in the past when you were hiring a new staff member. You know, just reach out to the training institution, talk to the program directors, to the faculty, you know, talk to your colleagues in the community, what type of experience they have had with the candidate coming out of that specific fellowship program. And then, of course, I'm from the University of Florida here up in Gainesville, and I can say that our 6 fellows are all ready to graduate, and they'll be successful in private or in academic practice. So I think for me, representing the pain program directors, I think we are able to keep up our high quality standards of training, which will then reflect in the excellent care of our patients and the safety. And I think I'll give it up to Jesse and talk about what FSIPP is doing for you and for us, to stay up on float in this crisis and also to protect our scope of practice and the safety of our patients. Thank you very much, folks.
Renee, thank you so much for an update on how the fellows are doing. And we are confident that the doctors of tomorrow are well trained. Thank you for doing that for us. All right. So guys, it's been a wonderful webinar. I'm going to close this webinar with a couple of things. What is FSIPP doing for you? Well, the first thing is we are doing our best, our very best, to keep you aware of the most current issues. Tonight, we have brought together the best minds in our nation, maybe in the world, for this webinar. You've received updates on the law, on telemedicine, reintegrating into the future, on the training of our fellows, on the really all the regulations and the infectious disease aspects of this disease. It's been marvelous. So I will get to the questions. However, first, what I'm going to do is I'm going to share the results of the survey with you. Now, we sent out a survey to all of our doctors, and here's what it is. There were 15 questions. So question 1, are you currently seeing pain management patients in your practice? Well, 65% of us said yes, 35% said no. Which factors are important in your decision to see or not to see a patient? And they were age, comorbid medical conditions, and patient level of pain. So on the one hand, I think we're balancing risk with patient need. Just because when we received the emergency declaration from the governor to not do elective procedures, those procedures may be an emergency to the patient with pain. Question 3, are you currently performing interventional spinal procedures in the office? 45% said yes. In the surgery center, only 10%. Both surgery and office, 55%. So about half the physicians in our specialty are doing both. Are you using steroid? Well, it's about 50-50, a little bit more, 55% said yes. Have you applied for government assistance? So there, on the SBA forgivable loans, 55% said yes. Payment Protection Act, 53% said yes. Florida state loans, we had 5%. And we had 25% say no, that they just were not applying for loans at all. Have you furloughed or fired staff? 35% said yes. Have you reduced staff hours? Here, almost 80%, that is 78% said yes. Have you reduced salaries in your practice? Well, as for your own, more than 50%, that is 51% of doctors said yes. Of staff, it was only down to about 2%. For both staff and physicians, it was up to 47%. Do you expect to recover financially, fully from COVID-19? Not sure was about 50%. Yes, almost 30%, and no, about 25%. What percentage of your patients are you seeing via telemedicine? 40% of doctors said 76 to 100% of patients. In the next lower category, that is 51 to 75, only about 15% of doctors. Less than half is just about 50%. Do you have enough personal protective equipment? Less than 40% said yes. And I'd like to remind you that one of the things that FSIPP is doing is we have obtained a very good connection for getting good PPE. It's really through one of our board members, through the generosity in the context of Dr. Julio Paez, and we're very thankful to Julio for this. and we have been supplying these at cost to people. So, and you can see that a lot of people need them. Are your patients signing COVID-oriented consent forms? 60% said yes. Have you or any of your staff tested positive for COVID-19? Well, 98% said no, and 2% said yes. Has any of your staff taken quarantine for possible COVID-19 exposure? Yes was 40%. So almost half of us have taken a quarantine. And those are the results of the survey. Just to finish up, FSIPP is, I'm not going to use the word donating because we're asking people to pay for the cost of them. But we're asking members to contribute what they can, and we're doing our best to get PPE out to our members. Next, please come to the annual meeting. It's going to be a fantastic meeting. It'll be at the Diplomat Hotel in Hollywood, July 16th. It'll be the finest pain meeting of the year. Wow, it's going to be excellent. Now with that, we will be having more of these, time to be announced later. Please stay safe and healthy. Good night. Oh, I'm sorry. We're going to cover questions now. Are we still on?
Yes, you're still on, Jesse. We still have 52 people on with us.
Terrific. All right. So what I'm going to do is I'm going to go through some of these questions. Now, the first question is from Malik. Malik, here's the question. So we extrapolate the future loss, and this is from one of our doctors who's getting in old money, but is wondering how far to extrapolate into the future for income, for what we apply for.
You're breaking up like crazy. I heard something about extrapolating, but I'm not sure if everyone can also hear him clearly, but I didn't hear the question.
Do we extrapolate future income, or do we count on old income?
Oh, for the extrapolation, no. The extrapolation formula was just for the month of April. So because the month of April has not closed, if you're talking about the part two, I'm assuming whoever the question that was asking was they're asking regarding part two. And David Vaughn, you can piggyback me, but the extrapolation is basically since the month of April has not closed, they're talking about the extrapolation for the remainder of April can be done in terms of our losses. Is that correct, David?
That's correct.
All right, next question for Malik. For part two of the Provider Relief Fund, do they count only loss of Medicare payment or all payer payments?
So that's the interesting thing with part two. It seems like as of now, they're counting loss of all payments coming in. And that's why the proportion of the funds that are going to be coming to you will not be the same proportion likely as the 6.25% as it is. So I mean, I don't think anyone knows the percentage of how that calculation is going to be done. If I had to take my best guess, what I would guess is if you're a practice that more heavily has commercial patients, but you still see some Medicare patients, that you would get a bigger chunk than the remainder of the patient or the population or practices that have just all Medicare. So I'm not sure, Dave, you can help me out with that.
I agree. It's all revenue, not Medicare fee-for-service income only.
Okay, thank you. The next question is for David Vaughn. Can you pay rent to yourself if the lease existed before the loan?
You can, but I'm not sure what good it does for you because now you got to count it as income. So it's a wash.
All right, fair enough. This question is for Dr. Miguel de la Garza. Is Zoom a permissible platform to use in telemedicine?
Right now, yes. And Zoom also has a BAA agreement, but there is a Zoom application that is medical that is specifically designed to be compliant. So pre-COVID, there was a Zoom medical that was compliant. Strictly speaking, Zoom is compliant now because of the HHS relaxation of the standards. After this all ends, then it would essentially you have to use the medical component. I also want to make a clarification. Thank you, Dr. Corden, for providing this. So, and this is at the end of the slide set. Specifically, if you make a telephone call, the codes you need to bill are different than for doing an in-office visit. Specifically, the face-to-face two-way seeing on the screen back and forth is what's necessary. So the 99441, 99442, and 99443, essentially those are billed in 10-minute increments. Those need to be billed if you were doing a phone call only without a visual component. Thank you.
Thank you, Miguel. Just a couple of things here. This entire webinar is going to be available on the FSIPP website. So anybody who wants to come and click on it, you can watch the whole thing. Another plug for our meeting, July 16th. And here is the final question. And this one goes to Dr. Harold Cordner. So what is the protocol for opening the practice and checking employees? Do we check employees weekly or just on the first day before opening? And what is the protocol?
Harold,
I got it. So the protocol is really going to be up to you. The suggested protocol is that you should test every employee daily for temperature, symptoms, etc. If they have a temperature, then you have to treat them as if they have COVID and quarantine them. As far as testing goes, blood testing, antibody testing, you would do that probably when you're ready to open up and start doing procedures again when the testing is available. There are several companies that will come to your office and test everybody, and it's a nominal fee. The antibody test is about $30. They will bill your insurance as well. So there's companies out there doing that now. You should remember, though, as I kind of explained earlier, is that your protocol should not deviate at this point from what you're normally doing. Keep up your standard protocols of sanitizing things, using sterile precautions, using masks. I would suggest highly that the patients themselves should wear a mask, especially if you're going to do a procedure. That is also in the guidelines as well, and CDC as well. So if you're going to start doing procedures, the patients should have a mask, at least a cloth mask, if not a paper mask, and everybody coming in and out of the building should have masks on. Additionally, you should probably screen those patients before they make. We have a screening in our lobby. We only let 1 or 2 people in at a time. No visitors are allowed in the building unless it's vitally necessary that they're a caregiver and they need help. But we have the patients wait out in the cars before we bring them in, so we don't have more than a few people in the waiting room at a time. So we're still, even though in phase 1, I would not let up too much on that until we get a little bit more to the phase 2. And again, I think that you're going to be different again if you're in South Florida versus some of the other counties as far as that timing of that goes. So protocols, if you have any further questions about that, I hope I answered your question. But you don't have to test the employees on a weekly basis. Just if they're coming, especially if they're coming back, if they've been quarantined or they had any exposure, certainly test them before they come back. That way you have a clean slate that you're starting with people that all either have antibodies or they're not exposed, so that you know what you're dealing with when you come back to work.
Thank you, Harold. Guys, we did get one more question in, and this question concerns screening for performing procedures or just seeing patients in the outpatient clinic. It is Gautam Kalyatanda. Are you on the call at this point?
Yeah, Jesse, I'm here.
Perfect. So what this is for you. Any patient coming into clinic, should that patient be tested? If so, is there different testing for a procedure or for a visit? And if so, when should that patient be tested?
So I mean, that's variable between, you know, different demographics. And at this point, we aren't testing anyone who comes into the clinic or who will come into the clinic. So we've already decided on opening up our clinics after, I think it's May 4th, May 11th, but there's absolutely no reason why you should test every patient who comes into your clinic. I don't think there's any role to test all patients who come in. And again, you know, the jury is out about all these antibody tests, even the rapid tests as well. There's lots of debate about false negatives, false positives. So I think unless you absolutely have a reason to test someone, I really wouldn't test all patients coming into the clinic.
Okay.
Can I follow that up with a question? What if you're going for a surgical procedure, say an implant, spinal cord stimulator, intrathecal pump, etc.?
Right. So
Would that change your mind?
Right. So you're talking about any them coming in for any kind of aerosolizing, you know, any procedure that could potentially aerosolize, right? So yes, then I would test them, but not otherwise. Not your regular patients who come into your clinic. Does that kind of
last point here?
Miguel, we're having trouble hearing you.
Your facility may have testing standards in which you perform surgical procedures, and they may require something that is different than what the accepted standard is within the state. And finally, last question, I'll open this to the whole board, is should you start doing procedures May 8th, or what resource would you refer to basically to get quote unquote permission for your area?
Harold, would you go on that one, please, about the future?
So yeah, I guess the question was, when should you go back to doing procedures?
Yes.
Number one in the office, and then number two in a surgical facility where there may be other patients that you can't account for, basically being cross-exposed.
So that's a good question. So certainly in your office, you should be right now only doing urgent or emergent procedures. Once the level 1 gets adopted, which is probably going to be in the next week or two, in your office, again, looking at the guidelines that we worked on at ACEP, low and moderate risk patients, you know, you should feel fairly safe in doing. Those moderate to high risk patients, you really need to consider looking at it. The patient, you know, an elderly patient in a nursing home, you really should think twice. One, about even the asymptomatic patients still can be carriers. And so bringing, you know, an elderly, frail woman from a nursing home and doing a procedure may expose you, your patients, your staff, but also puts them at additional risk as well for being exposed to being the procedure. As far as the ASC goes, hopefully most of the ASCs are going to be following pretty strict guidelines for universal. So whether they're going to be doing the same screening for your patients as well as the other patients in the surgery center. Certainly universal precautions are going to be doing that. You should follow the same exact very strict guidelines. And remember, this is phase 1 only. So it's not like we're out of the woods in phase 1. We're just kind of testing the waters, and you can have a problem from going from a phase 1 and all of a sudden you get a spike in cases, and then you may go back again and put the ban on. So don't think that this is free and clear. You're going to have 3 phases. So again, first phase is we're going to do elective cases. We screen them carefully. And then in a few weeks or probably a month, I'm sure things will change a lot and get a little more loosened up.
You're on mute, Jesse.
Can you hear me?
Yep.
Okay, you guys, I would like to congratulate everybody on a fantastic webinar. This is up to date, up to the hour, real information on how to conduct our practices, how to carry on, and how to go forward into the future. Fantastic, everybody. Thank you so much.
Thank you so much. Have a great night, everyone.
Thank you.
Thank you. Good night.
Good night,
Thank
everybody.
you. Thank you.
Thank you.